Well, I am thrilled to be here, and I was really pretty intimidated because, of course, John asked me and said, you can do this. And I'm like, but TCOM, I only know about this much. And I will talk about it a little bit here, but you just have to correct me when I'm wrong, because this is a shared learning experience up here. And that's what's exciting. And another thing about John is John does not think small, okay? So he says, no, there's really great intersection between what you do and what we do. And I said, okay. But he is right. And it was an opportunity for me as I was preparing to think more about this, but I'm sure you have more ideas. I'm going to focus a little bit on what I know of person-centered care, and then, which is about this much. And then I'll talk about value-based payment in sort of the traditional healthcare system, the what do you call it, physical healthcare system, and then think about the intersection of what can be learned to move forward whole health, the bigger concept of health, okay? So I will get going. Opportunities and challenges. That's our lives, right? Okay, I have no disclosures. I actually have to look here to see my slides. Okay, learning objectives. After this educational activity, I hope that you will be able to recognize the difference between delivery system and payment model changes. I think that's really helpful to think about because you've been working on delivery system changes. And that is needed to have payment system changes. And they can work hand in hand to really increase impact. So we're going to talk about the differences between those and how they work together. Be familiar with a range of value-based purchasing arrangements because it's where what you need to think about as you try to change the care change the payment for the care that you are working so hard to deliver. I am a systems thinker, no apologies. And then understand how person-centered care may add to current value-based payment strategies. There is absolutely an incredible amount of good intention around addressing social determinants of health. The trick is, how are we actually going to do this in a way that matters? So, okay. First, delivery system models versus payment models. Okay, person-centered care, as I understand it, again, apologies, is a delivery system innovation. You are changing the way that care is delivered and the why and the how. Value-based payment is a payment system innovation, and I'll talk a lot more about that so that you'll know what I'm talking about. Okay. New delivery systems are often the vehicle through which payment models are implemented. But it is absolutely true that first you've got to figure out how to deliver care differently before you can figure out how to pay for it differently. And the payment can actually incentivize and support the delivery innovation. All right, here's my working. I didn't get John to vet these slides, but my working definition of person-centered care, a holistic approach to care delivery that incorporates the whole being, the whole person, their context, their individual expression, their preferences and beliefs, and also family members and caregivers. How'd I do? Okay, yay. All right. Patient, I did it. I meant to put person. I am so sorry. Because guess what? The literature is all about patient-centered. It was supposed to say person-centered. Okay, focus on outcomes that are meaningful to persons, to clients. That is actually true value. And so when we talk about value-based payment, you guys have been focusing on where the value is. Okay? It empowers and engages to increase the likelihood of success, promotes respect. I'm just saying this is from the literature. This is not from John. This is not from our TCOM team, okay? Promotes respect, culturally sensitive care, reduces stigma, racism, disparities, promotes equity, okay? These are all incredibly valuable. And while y'all have been working over here, see, I am from the South, there's been this sort of parallel conversation in physical health care, and they need to come together. Okay, again, I did spend some time in the literature, so I hope that it resonates with what you already know, but I had to come up to speed. What are the challenges? One of the things that was noted a lot was professionalization of care delivery, that the person, the family, doesn't know what's best for them, right? So I definitely feel this being in a quaternary health system with all these ultra experts, and you say, I don't really want to take that medication because I can't work. And they say, no, that's really what's best for you. I know. So it's this professionalization that is a real problem. Dollars. I'm the nicest economist you're going to meet, and I still think dollars are important. No margin, no mission. Okay? A lot of that is driving. You need to take care of this many folks in this time period. There's not enough time in the day, and the resources are limited. This was interesting. This came out. Few nationally endorsed or widely agreed upon metrics for outcomes that can be used for outcomes improvement. And, did I get it right? This is the transformational part of TCOM, is to actually come up with these measures, right? Limited evidence of the structure and process changes that are needed to deliver person-centered care. I cannot believe I've got patient-centered throughout this slides. I will go home and change it, I promise. Okay, so it's not just that, once we have these outcomes, we need to know now what works. How did that, that score change? How did those outcomes, how did the situation become better? And I would say, working on this too, right? So first you collect a lot of data, and now you use this data to identify the structural and process changes that you need. And then last, and this is a big issue, I don't have to tell you, right? Lack of system and information integration. In order to do this well for the whole person, you need a lot of information at the point of care and at the population level. Okay, so that's what I know. I hope it's enough to do the rest of this talk, but I encourage you to tell me what I don't know, because this is really exciting stuff. Okay, so what is value-based payment? I bet a lot of you have heard this word sort of thrown around, and you're like, what is it? It's just those bean counters again. It's actually this, this parallel, this fundamental shift that is happening on the physical healthcare side and brings huge opportunity. It is a payment program with trying to use the financial incentives inherent in payment to promote the outcomes that you want, the quality of care, okay? Early on, this has been heavily focused in hospital payment. And the reason is there's a lot of money in hospital care. So it was the first place that we saw this happening. We've seen it now moving out towards other types of providers, physicians and other types of providers. And that was a lot of purpose talk. I won't spend a lot of time there. I want to focus now conceptually, what are we trying to do, and what is the spectrum as we move towards more integration. Okay, why value-based payment? You're like, yes, why am I in this room listening to this talk? Okay, sorry, I'll talk to this side of the room now while I look at this set of slides. So, fee-for-service payment is exactly what it sounds like. Do a service, get a fee. Fee-for-service payment has dominated service delivery for decades, all right? But what it does is just encourage more. It just encourages the service. It might not be the right service. It might not be a good service. It's just a service. And so it doesn't address what are critical things that we need, which is improving the health, broadly, the whole health of the people we serve. It does not address care experience. It does not address cost. In fact, fee-for-service is highly inflationary because you just need to do more to get more. So, value-based payment is really intended to change the paradigm to reward value, not more, okay? And how many of you have heard of this, the triple aim? This is a very different room from the one I'm usually in. All right, briefly. The triple aim says we can actually do all of these things at the same time if we are strategic. We can improve health of populations, including health equity. We can improve the patient care experience, improve quality, and we can lower costs of care. That actually was incredibly transformational around the year 2000. And before that, we used to talk about it as the iron triangle, which is if you push on one, it has to come out, it has to be somewhere else. That doesn't make sense. That's not, it's called the iron triangle, but that doesn't really sound right. Anyways, so the idea is if you want to lower cost, you have to lower quality. That's the only way. There's this strong relationship. If you want to improve the patient care experience, you increase cost. And so this thinking dominated delivery of services, delivery of healthcare, delivery of other services. And around 2000, folks started saying, I don't think that's true. I think that a lot of times we provide all kinds of care that isn't necessarily patient-centered, person-centered, isn't actually improving their outcomes, isn't actually good care. It's just driving up cost. So can we, again, centering around the person, say, what do you really need, not just what can I deliver? So the classic case is the patient who shows up at the emergency room every day for 365 days. Very, very expensive, and they are sick. But why? Well, because they're homeless, because they don't have, good access to food. Some of the very basic social needs are not being addressed, and so they're showing up in the healthcare system when what they really need are social services. Okay, so the triple aim has really driven the conversation about how to transform delivery of care in a way that makes sense for the person, but also achieves these goals. Okay, and a lot of the way that they're doing that, and you heard the talk from Purva yesterday, is alternative payment models, because we can use the money that we spend to pursue the goal that we know is right. Okay. I actually didn't know that Purva was speaking when I made these slides, and then I'm like, John, her talk looks just like my talk. He goes, oh no, I'm sure it'll be very different. and he's right. Okay, CMS is leading the way, heavily in the Medicare space, but more and more pushing on Medicaid, and the more vulnerable populations, the dually eligible. And okay, they started in around 2010, or 2008, I believe, was the first alternative payment model. It was in hospital care. And so a lot of my research was focused on that because that's where it was happening, and now it's spreading. Okay, with the passage of the Affordable Care Act, I've already covered this. We saw a lot of expansion in this area. And they are doing a lot of demonstrations, and also learning systems, which is really, you guys are a collaborative of learning systems, okay? CMMI, which she represented, they have learning and action networks. You can see these slides later and look at it if you want. And then they're working on developing evidence to be the foundation for further implementation. Again, what you guys are doing as well. So it's sort of been happening again in parallel. All right, for the rest of the time, most of the rest of the time, I'm gonna talk very conceptually about what is value-based payment and how does it include both those system, practice, delivery changes and the payment changes. So at the far end, we'll start by talking a little bit about pay for performance, which is really just a tweak of fee for service. And then we'll move all the way down to what is the most integrated, which is very difficult and to achieve, but we do have examples of it, where everything is in one organization, and that really helps to align incentives. We'll get there. Okay, first of all, pay for performance. Okay, I'm moving over here now. Talk to you guys. All right, what is pay for performance? Who's heard of the term pay for performance? I gotta get people to wake up here. All right, woohoo! Resonating just a little bit more. Okay, so pay for performance is exactly what it sounds like. You perform, you achieve some metrics that the payer cares about, and you will get a bonus. Sometimes if you do quite poorly, you'll get a penalty. But these bonuses and penalties are sort of layered over the more traditional, whatever the other payment system is. Okay. Talk quickly about two big hospital pay for performance programs that you may have heard about. I'm talking about these not because you really need to know about hospital payment, but because it can help you think about how you step a toe in the water on value-based payment. So this one, the Hospital Readmission Reduction Program. Medicare instituted this, and 2008, I think. Oh, sorry, brain fart. The Medicare program penalizes hospitals for higher than expected 30-day readmissions. So what's a 30-day readmission? Turns out, when this was implemented, that 1 in 5 Medicare beneficiaries will be back in the hospital within 30 days after discharge. That's incredible, right? Who wants to be in the hospital? Who's spent any time in the hospital? Right. How awful is it? You don't want to be there. That is very un-person-centered, okay? So Medicare said, something's going on. This is not, are they not getting the care they need in the hospital? Or maybe they're not getting the care to transition them home, right? My favorite story in this one was my 68-year-old father-in-law was in the hospital, and then he came home, and it was my husband and me, and my sister-in-law, and there were like 2 PhDs, a doctor, and a nurse trying to understand these discharge orders. It was hard, right? So that transition home is a critical time. Hospitals said, we don't affect that, that's not really our problem. And CMS said, I don't care, do something about it. You get a lot of money, figure out those transitions home. So, right now the program penalizes up to 3% of Medicare revenues. It is attention-getting money. Most hospitals have 50% or more of their patients are Medicare. So these are millions of dollars that hospitals are very unhappy about these things. So, okay, the average hospital penalty, however, is about $200,000 a year. Still, not nothing. And in 2021, Medicare assessed $521 million in penalties under this program. So there's no bonuses here, it's only penalties. All right, but it's big dollars, it's attention-getting dollars. and it's tied to the size of their revenue. So, oh, I forgot about this. It's my little thing of what's a 30-day readmission. All right. One more program. Can I go back? I can. All right. One important thing to think about with this program is it is relative to other hospitals. So there is a relatively elaborate system where they say, do you have higher than expected readmissions for the patients that you serve? And by the way, it's a readmission to any hospital, not necessarily yours. Okay? So it's relative. And so if other hospitals are improving and you're not, your penalties start getting bigger. So there's something desirable about that and something scary, because we've actually found that safety net hospitals, which are those that serve 25, 30% uninsured sometimes, are much more vulnerable to these penalties. Okay, second program, and then I'll move on out of pay for performance, but it is the toe in the water. This is overlaid on the current payment system. Is something called the Hospital Acquired Condition Reduction Program. We actually call it HACRIP. Yes. All right. It is the Medicare program that penalizes the 25 worst performing hospitals. So this is very different. It's not relative to performance. It's just the worst 25%. And they're ranked based on something called hospital acquired conditions. What's a hospital acquired condition? Infection. Oh, do I already have it there? Yes. Cheaters. Falls. So it's something that happens while you're in the hospital. So it's arguable that the hospitals control this more. And so they just need to be better than that set. The problem is the person who just missed it and the person who was just over the line as the 25%, the worst 25%, that's like $1 million or so. So there's this arbitrariness, and actually we've shown that it's really arbitrary depending on how you measure these outcomes. So anyways, I'll share that paper with you. Olga, is she here? Yay! Olga and I worked on that paper together. It's very cool. I don't know, I should have asked Purva what CMS thinks of that. Okay, so this penalty, 1% of Medicare revenue, still large, but a little bit random in the sense of, are you just above or below that cut point? So 774 hospitals were penalized, and very often, well, that's the same hospitals who are taking the readmission penalties as well. So it's very, it's interesting. It is driving change, which is good, but it's also a good way to have CMS make money. So, okay. So that's pay for performance. We're going to move on to something that involves a little bit more system integration. Okay, moving over to this side now. Okay, patient-centered medical home. How many of you have heard this concept? Good, good. What is that? It focuses on not just this country doctor, the one doctor taking care of the one patient, but really thinks about a more team-based approach. And you see how this is trying to shift the model, the delivery model of care. Evidence-based decision-making, there's a whole set of things. It was signed on by a number of medical societies, but the idea is that it's not just the patient coming into the exam room, me listening to your questions, answering and writing a script, of course. It's more than that. It's managing at a much higher level, team-based. Care coordination and management. You see how other service delivery, more whole health concepts can come in to this model. It includes appropriate payment to support wraparound services. So it's not just the fee-for-service. There's basically, in patient-centered medical home, a lot of times there's like a PMPM, per member per month amount that also goes to the practice who is investing in these types of services. So there's no focus on the outcomes, it's just focusing on, are you building the structure? Okay. Shared savings plan, a little step further. where we actually try to put some incentives tied to the outcomes. There are shared savings programs, mostly from CMS. It is voluntary. It encourages providers to come together. So it's the payment. We need the structure change, and that is the accountable care organization. So they're coming together. Sometimes it is a health system. So they've already got this sort of a high level of integration. But sometimes it's more of a virtual integration. We will come together contractually. We will work together to be accountable. They're held accountable for particular costs and quality measures. It's typically in primary care, but doesn't have to be. And it's been mostly focused on Medicare, although we do see some now implementation in Medicaid. Again, it's a vehicle through which we can think about more broadly what we're bringing into this. All right, it is fee-for-service payments with bonuses and penalties. So again, it's quite a bit of just an overlay on the existing fee-for-service. But if you talk to any provider, they don't want their fee-for-service payment to go away. You cannot scare them that much. So these, again, we're trying to move things along a continuum. Okay. Bundled payments. This is quite different from some of the other things that we're talking about. In fact, it's quite fragmentary, I will say. What is bundled payment? It is episode-based payment. And what it does is pays fee-for-service with cost and quality metrics, but it's for a particular episode of care. What is an episode of care? Well, having a baby, that's an episode of care. And in fact, one of the early bundled payment things that we saw. Now we tend to see it around surgeries or around acute events, which often is not the folks that you're dealing with, right? So bundled payment in a space where you have high needs populations that don't have an episode. Their life is the episode in some ways. So it's hard to think about this, but I just want to talk to you about this in case you hear this term. For Medicare, providers get to select the conditions. Again, toe in the water. They're trying to encourage providers to think along this way. And basically you can make, I say basically a lot, don't I? You can make different virtual organizations, including post-acute care, long-term care, Medicare pays, you know what Medicare pays for. Medicare only pays for a brief period of time after a hospitalization, but you can include those providers in your bundle. And so what we see is we can use these mechanisms to make small virtual organizations to try it. I do think that bundled payment strategy is not a long-term strategy. It's a short-term strategy to encourage folks to think more system-wide. Okay, move over here. Capitation. How many have heard that term? Okay. If you're as old as I am, which is not as old as John, capitation was a dirty word in the 90s, right? Because many people felt that capitation gave the money to the HMO, Health Maintenance Organization, and their total incentive was to not deny care. I'm simplifying, but that was a lot of the managed care backlash, as we called it. All right? So when things came around again, we moved heavily away from capitation. But it had some desirable things in it, because what it did is say, I will give you this set of money, and I want you to do what is best for the person, whatever they need. So it's very different from fee-for-service. Fee-for-service says, I think you need 10 MRIs this year, okay? It's do a service, get paid. This says, okay, here is a person I'm responsible for. How can I use these funds to achieve the best outcome. The problem was many HMOs were also for-profit, not all. There is undoubtedly an incentive to minimize care unless you have all altruistic people, which is hard to count on as an economist. Okay, so would you agree too? Yes. All right, okay. But what we saw the second time around after the 1990s was that we do have more full risk again, but with other measures of accountability that ensure particular things are being provided. So a lot of performance metrics alongside the full risk. So what does it take to bear full risk? You have to be relatively large, right? So if you are completely responsible for a population and 1 or 2 of your folks need a heart-lung transplant, need a lot of services, it can bankrupt you. So that's very undesirable. It's actually the question I asked Provo, which is, we have a lot of small providers, and if you put them at full risk, even for a set of services, we call that partial capitation, and there are some high needs people, you can be bankrupted, all right? So you have to be very careful of who you take on. Well, that's what we call cherry picking, okay? So there's a lot of things that you have to be very careful about and think about the size that is needed to bear risk, and that's inherently a problem. Okay. So a lot of times, and that's actually the answer she gave, is that we have umbrella organizations who get the full risk, but then everybody below them is just paid fee for service. So is that gonna work? It's a challenge, maybe. That's why more integrated organizations, I think of the Kaisers and the Intermountain Health and those folks which have a very strong common structure and culture, I think it can work. But the more that you have an umbrella organization that is just an aggregator, and often they're for-profit, it's questionable as to whether it's really going to do the promise of alternative payment. Okay. Last, and then I will, how am I doing? Am I doing okay? Yeah, okay. Provider-sponsored plans. 10 minutes, okay. I can do that. I think I'll be done before that, and you can ask me questions. Provider-sponsored plans. This is sort of the ultimate level of integration, where everything is under one roof. It's not just an umbrella organization that has contracts below. It's not just a company that has contracts, but it is full integration, where, and again, I'll bring the Kaiser and the Intermountain Health, Geisinger. But it's a high bar. It's incredibly hard to achieve. I'm just saying this is the spectrum. The argument here is that you have maximum financial control, and you have, to the extent that the leadership of the organization is our providers, you have their vision for how to organize and how to deliver. Potential efficiencies. People talk about, if you have lots of intermediaries, things get pulled out. So that's something that is argued. And the alignment may support better quality of care. So that's the far end of the spectrum. We started at fee for service, we went to pay for performance, and all the way at the other end is provider-sponsored health plans, of which there's not a ton. Okay, so value-based payment, promises, but a lot of pitfalls that we need to keep in mind as we think about how to leverage what's being learned on this track with the track you're on. Okay, so increasing alignment of providers to support this triple aim. If you leave here and know what the triple aim is, I am going to be so happy. Better care for populations, patient experience of care, same or lower cost. All right, so increasing potential for cost savings and quality improvement. it's more systematized. We're building in the incentives to improve things in the system, both the way that we deliver and in the way that we pay. The problems definitely requires often, well, for the more integrated models, we need larger organizational structures. That's a big problem. I live in Kentucky, and we have a lot of really rural areas, which happen to be where a lot of our high needs folks are, and we just don't have the density, the size, the organizational size to address. Okay, these letters are too small for me to read. Sorry. But for risk bearing, that's an important, you need size. Economists call it economies of scale. We need size for risk bearing, we need size for information sharing and for investing in these infrastructures. They cost money. We need accurate measurement. A lot of the measures that we have, again, I've been on this track, a lot of the measures that we have, a lot of my publications, my 99, focus on how less than optimal our measures are. They make a lot of sense. It makes sense to tell hospitals, we're going to penalize you for hospital-acquired conditions because they shouldn't happen. We call them never events. It makes sense. But the way that we do it is, frankly, almost random. So how are they supposed to improve? Okay. It relies often on narrow networks. Who's heard that term, narrow networks? Okay, very few. A narrow network says, I'm going to find a small set of providers and have them take care of all of this set of people because they'll get good at it and they'll have the volume they need to provide the services for what I'm going to pay. The problem is it also dramatically limits choice. So if you've ever been, wait, who works for the University of Kentucky? Who selected the University of Kentucky's delivered health plan, right? You have to go to a UK provider. I did not, because choice matters to me, all right? It's the same thing here. We see a lot of narrow networks to control costs, but it really limits choice. Okay, so providers and organizations, many are getting left behind. And we're actually seeing the alternative payment models, they're leaving the rural areas behind. They're leaving the safety net providers behind. Because they can't compete. They can't, their populations have a lot of needs that are not accounted for in the risk adjustment. They don't have the economies of scale, et cetera. So that's a huge problem because one, we're actually increasing the gap between the haves and the have-nots. If you're in a highly urbanized area where you can get the scale, that's good. Other than that, sorry. So what is the path forward? It's uncertain, and I don't mean to scare you. We need to learn together. Maybe we can learn some of what's been happening on this physical healthcare track. There are certainly lessons learned. We need to first focus on the structure and process changes that support person-centered care before we overlay a financial incentive. In the traditional physical healthcare space, the start was to incentivize structure and process changes, and I think that's a good lesson. First, incentivize building the right structures before you incentivize the outcome. All right. Shared learning models are incredibly important. And having sort of this, I'll call it the cone of silence, peer sharing, so that you can understand the changes that you're implementing and the impact, that you can share what's working and what's not working. All right? And then eventually, getting to scale, we start having demonstrations. CMS did the demonstrations in a couple of ways. Volunteer, so organizations could learn whether they wanted to be doing bundled payments. And market-wide, because often if you're the only person doing it, it's a very different feel and outcome than market-wide, statewide, citywide, countywide. All right, and then start pursuing integration. Unfortunately, the mom and pops in physical medical care are not, we're moving past, and I'm trying not to say anything negative, pursue integration. All right, I am done, and thank you for your attention. You are an awesome audience to listen to an economist for that long.
I was just wondering if you had any insights on the impact that now Medicare will be able to directly bargain on medications in the new legislation, and what impact that'll have, first of all, just controlling healthcare costs, and also how might that be integrated into future value-based purchasing stuff we see coming from CMS?
So the first I can answer relatively easily. The second, I'm not sure. So the question is about giving Medicare the authority to negotiate drug prices. When Medicare implemented Part D, which is the section of Medicare that covers medication, part of the political maneuvering said, okay, the pharma industry really opposed having that negotiation because they like to make the prices that they make. I'm not making any negative comments about the pharma industry, but they have 12% returns annually, which is higher than anything else in the market. So there's a reason, because those drugs are sold through hundreds of Part D health plans, and that really diffuses the ability for anybody to negotiate with pharma on drug prices. We have now recently passed legislation that says, okay, come on now. Let's allow this. Medicare is probably the biggest purchaser of medication in the US. So I think it will have a pretty significant impact on the prices that are paid for by Medicare. To the extent that commercial payers can follow on and have, say, most favored nation clauses where if Medicare gets that price, you have to give it to me too, we'll see even more. We are still the United States, and so I think many innovative people will figure out ways to still support higher level of prices if they're not included, say, in a formulary. But I do think it's a really important move to control costs, especially some of these very expensive medications. They're wonderful, but the prices are really high, and that's an equity and access to care issue when those prices are that high. How will that be in value-based payment? When we get to the higher levels of integration, I could see medications included. When you're in full or partial risk models, the medication would be included. Obviously, some of these lower levels of integration, it's all separate. Does that make sense?